presentations. That was different. So what we're going to do is we're going to go into presentations. We get quorum. We'll go officially to be cognizant and respectful of everybody's time. So we're not going to officially come to order, but we will move into presentations. And with graciously the leadership from Methodist here, and knowing you got a hospital to run, we will ask you to come up first with the presentation. So Jeff, just for the record, depending on where you at, if you are in a if you're like at a pause, and we for some reason get quorum, I'm gonna hold like you're at a question point or between a piece. I might just hold you and call official order and give it back to you. So
that'd
just
be
on
fine.
record.
Sure.
Okay.
Yeah,
Right.
absolutely. Well, thank you to the board for having us here to present our 2025 results of our community impact. My name is Jeff Prohaska. I'm Chief Strategy Officer for Methodist Health System. Wanted to start out by introducing our team, and here with us today is our President and CEO, Methodist Health System, Josie Aboud. From my team is Steve Jackson, Antonio Rodriguez, and then you'll hear from Becky Gisba from Methodist Hospital a little bit later. But we wanted to bring our team down so you recognize some faces as we're out in the community. Today we're going to go through updates on our anchor service lines. We'll talk a little bit about challenges of workforce in our community, presentation about our efforts in social determinants of health. And then, as we always conclude on these presentations, is to summarize our impact in dollars of our community benefits. So where we begin is a bit of a new approach. We have typically come and aligned our presentation, our updates to the actual needs from the community health needs assessment. But as we went through the year 2025, we really attempted to integrate into our core strategic plan the efforts in the community. One of our most priority areas, we call them pillars within the health system, is our commitment to community. And how we plan is with our anchor service lines. Primary care, cardiovascular services, oncology, women's mother baby NICU, and behavioral health are how we plan. We should do our community involvement no different. So at the beginning of 2025, I approached the service line leaders and asked them to develop strategies for impact in the community and then report back quarterly the progress of their efforts. Now, one thing is a little bit self-serving. It made it very easy for me to prepare this report for you today, as opposed to trying to herd all the cats and get them all put together at the beginning, at the formative stages of the plan. But with this, also defined focus allows us to really hone in on fewer areas. We think that deepens our investment in those fewer areas and creates a greater impact. So I'm going to go through each of the anchor service lines, and some of these you will have seen before. What I really tried to do is bubble up to the top the new initiatives, the new efforts within these, and highlight our year of 2025. So the first area is primary care, and within that, our Methodist Community Health Clinic. It's a free and reduced fee clinic that's located at 26 and Douglas Avenue. In 2025, we onboarded 2 bilingual nurses. We incorporated behavioral health, so licensed mental health practitioners are now practicing out of that clinic and integrated into the primary care aspects of healthcare there today. It serves as a great location for our community health workers, and Becky will present a little bit about them later. But this is a place where we can land and have engagement with patients that have challenges, that have needs, have been discharged from our hospitals. We're taking actual medical practice in a specialty form to the Methodist Community Health Clinic, with cardiologists and obstetricians providing care on site. We've invested and grown with echocardiogram and EKGs offered in this free and reduced fee clinic. We offer programs that help patients that are struggling with access to pharmaceuticals, whether it's convenience or cost. We have programs to get them the medications that they need. We have created a new location for training. We're really trying to build up the pipeline of talent with interest in healthcare in our community, and this serves as a great place for our nursing students to shadow, build interest in community engagement, and hopefully take that along into their future careers.
Recording in progress.
And then the last piece, we did start up a partnership with the Douglas County Health Department for tuberculosis screenings in high-risk immigrant populations. Next, also within primary care, is our mobile diabetes unit. We're seeing 2,200 individuals annually. We saw 100 different locations that we screened across our communities. What's new is we did add a new unit. We're up to a second unit, one large one, and then one that's smaller and more nimble and can get into tighter parking lots and smaller locations. Still offering diabetes screenings, education, and referrals. We added child development screening. We've been partnering with the Douglas County Health Department for pediatric lead testing, and another clinical site for future nurses to do training and engage with the community. Something we're really proud of is our 4th annual health fair held at Coons Commons. It's in partnership with our Healing Gift Clinic and Coons Memorial Lutheran Church. It does really serve as a hub for our community partnerships, where partners can come into a singular location where people are already there for the food pantry and Healing Gift Clinic, and then we can engage with them in additional services. We did 400 plus screenings in education, and at this annual event, we offered flu shots. You can see the picture there of our mobile diabetes unit. Statement on this 4th annual was our largest yet and had the largest number of partners involved. Our next anchor service line is cardiovascular services. Much of this is done in partnership with the American Heart Association, really trying to build motivation within this anchor service line and increase engagement. We started offering some of these screenings to get people involved to employees. And we were really surprised by the participation that our employees stood up and came and participated in these events. As part of this, we planned and chaired the Go Red for Women event. We participated in the Omaha Farmers Markets throughout the summer. We coordinated blood drives that was done in partnership with the Nebraska Community Blood Bank. And with the American Heart Association, we participated in the Heart Ball and their Heart Walk. And as I mentioned earlier, the Methodist Community Health Clinic is offering cardiovascular services on site. Oncology, next couple service lines I really want to highlight. As I mentioned, we kind of changed our approach to align these with our anchor service lines, and oncology really got on board in 2025 and deserves a little bit of a carve out here. Number one is that they created a role. It's a community engagement coordinator. Their sole role is to be out in the community with the goal of increasing early cancer detection, largely in part done through screenings, and reduce mortality rates. Now, what we tried to do is align this with our core competencies of our Methodist Estabrook Cancer Center. We have specialists and we have surgeons that are trained and focus on lung, breast, colorectal, skin, and prostate cancers. We wanted to make sure we aligned with those core competencies so that we had those types of assets and those types of resources available for the community. With that, we also recognized that we had to take this outside of our cancer center and into the community. We did that through two methods. One was through mobile outreach. The other was by engagement with partners across the community. Also part of this, and next time when we scheduled to do our update, we've been investing in the ability to monitor and analyze outcomes data. So standing up a real robust system for identifying and really measuring our impact and seeing if the efforts that we're putting in the community are working surrounding cancer. One of our highlighted programs, and I've presented this one before, yes, we're doing 3,800 mammographies across our community. This mobile coach is going to employers, it's going to underserved locations, and it's booked out for the rest of the calendar year. Very successful and engaging program, but probably more importantly is the stories that we're starting to hear. I'm just going to read this one real briefly, but a patient at the Heart Ministry was diagnosed with an aggressive cancer after a baseline screening on the coach. She was referred into Hope Medical Outreach and provided financial assistance through her cancer treatment. Without the mobile mammography coach, she likely would have delayed screening or not had a mammography at all. Her cancer likely would have been more advanced and limited the treatment options and survivorship. We're making real impacts by getting out into the community, providing access, identifying cancer early, and improving outcomes.
So would you officially call it the coach?
It is a coach. That is correct. The mobile
The
mammography
coach,
coach. Yes. Now with this is our overall cancer screening program, and these are community screenings. And I put the challenge out to this team, and I thought it was important to make an impact, and they heard it. 96% increase from 2023. Almost doubled the number of community screenings that are being performed. That's done through improved access. They're getting out there. They're taking these screenings into the community, and also commitment and engagement. Now, we have to be welcomed into these locations. We have to be invited into these locations. So that takes a level of commitment and engagement that's required to build that trust to offer screenings in the community. Some measurable statistics around the cancer screening program. 658 abnormal findings were detected in 2025. 623 of those required follow-up care. Now that's where that integrated approach is absolutely necessary. It's one thing to detect cancer. It's one thing to identify it early. It's next is you have to get them plugged into the care process early and immediately. That was accomplished on 623 of them. And really what we're trying to do, at the end of the day, the program goal is to reduce late-stage diagnosis. That improves outcomes. That improves survivability. It lowers healthcare costs and increases health equity. This is for everybody. Our next anchor service line, Women's Mother Baby NICU. I don't know if you know this, our Methodist Women's Hospital, they're in their 15th year. We just celebrated the 15th anniversary. Definitely recognized as a role of the regional leader in women's health. Now with that comes some things that we do that are community oriented, but these things are offered within the hospital, and my next slide will go into what we're doing within the community. But inside the hospital, we're doing a NICU reunion. These are the families that have babies that really struggle with their health after birth. And that annual reunion is now attended by 500 attendees. We're offering a Remembrance of Life program for those that have suffered with pregnancy or newborn loss. Advocacy work, again, leader in the community, that advocacy for national stillbirth prevention, and established a Meds to Bed program. There's a number of patients that come through the hospital that struggle with access to pharmaceuticals, whether that comes from a cost perspective or just a convenience or access at all perspective, and that Meds to Bed program makes sure that they get the medications that are needed while they're still in the hospital. Now, shifting gears into what's going on outside the hospital and into the community, a lot of partnerships. I think as a regional leader in women's health that we strive to be the best partner in this space. One of those is car seat safety with Safe Kids for Nebraska. A lot of different and new partnerships with IB Black Girl, specifically around lactation support, childbirth education, and doula training. 2 community support groups were established in 2025. One was a mom-to-mom peer support, and the other was for perinatal bereavement support. Partnering with the Nebraska Diaper Bank for a diaper drive. Getting out there and leading in promotion of breastfeeding is a big role in the health of our youth. And then last, as a duty, we feel as a regional leader in women's health, is to help lift up our rural community partners, hospitals that exist within birthing deserts, and help them provide their future is sustainable. Next anchor service line, behavioral health. I hope that you recognize Methodist Community Counseling. It's a well-established program, been in the community for many years. It's licensed mental health practitioners that are on site. They care for students and their families. They're in all OPS middle schools, all OPS high schools, and all of the alternative programs. What's new is we have new locations on the Metropolitan Community College campuses, expanding access not only there, but into other portions of need. Some key statistics on our Methodist Community Counseling program, almost 11,000 therapy sessions. That's 12% more than last year, serving about 1,500 individuals. One thing of note, there's a 6% no-show rate. We compare that to a national standard of 25 to 30% no-shows. I think what it really demonstrates is that being there on site in the schools provides access, reduces stigma, builds trust, and is effective in getting the care that these people need. Our two busiest high schools are Central High School and South High School. Meeting that need, we expanded both of those programs to 1.5 FTEs each. We're partnering with OPS, Project Harmony, and Charles Dew to create the Benson Community Health Center. Then I think a stat you might find interesting, in our history of being into the schools, the older teens were the ones who were most frequently, really the majority of our clients within those schools were older teens. We saw a shift, specifically last year we saw this shift, where students' age reduce. Now our majority is those of younger teenagers. 11 to 15 was the largest cohort. So it could mean that we're driving that age down, reducing stigma, and people are asking for help at a lower age. It's possible. There's other ways that could go. It could be that there's a heightened demand at that age group. We're still trying to study that and decipher what that means. I have presented all the programs and services coming with Methodist Jenny Edmondson Behavioral Health Hospital. Today, wanted to announce that we plan to open that hospital in partnership with Acadia, nation's leader in behavioral health, in Q2 of 2026. It's here to serve the entire metro. It's conveniently located just across the river in Council Bluffs and right off the interstate. It is for both communities. Last piece before I turn it over to Becky is something that we've noticing, I guess, in a trend year over year and affecting us, affecting other health systems, affecting the community, is a bit of a dearth in healthcare workforce. I simply just listed off a number of our impactful programs that we offered last year. We're trying to get out there and increase the overall bandwidth of the healthcare workforce by generating interest in healthcare careers. Pause there if there are any questions before I turn it over to Becky, and after she presents on social determinants of health, I'll come back and close and can answer questions then too.
Yep, Jeff, let's pause for a minute to be officially on record. So for the record, there's a copy of the Open Meetings Act on the wall. And with that announcement, we will call roll and officially call the meeting to order. Roll call, please.
Wade, Festerson, McNally, Rogers,
Here.
Weiss, Jones, Wilkin,
Here.
King, Espinoza.
Back on you, Jeff.
All right, thank you. Yes, go ahead.
Jeff, I had a couple questions. The 26th and Douglas site, do you track zip codes? And could you give us an idea of the most prominent zip codes that participants are from in that area?
It's under Becky's tutelage.
Oh,
Offhand,
okay.
do you happen to know? If not, we'll run you a full
I'm
report.
just curious.
We'll run you a full heat map on it.
Okay, and the locations for the mobile mammography?
Yes.
You said it was by invitation, but can you give us a sense for where those locations are in terms of invitations?
Go ahead, Steve.
Most of the
I'm gonna need you to come to the mic, Steve.
Do you want me to do it? I got it. Okay. The employers all around the community were invited in. They feel it's a convenience for their workforce, and it does promote health within there. In terms of the community locations, it's not for profits. The federally qualified health centers. We're at each, and we do some health fairs as well.
Thank you.
Go ahead.
With that, it sounds like your coach is booked up for 2026
Yeah.
already. That's incredible. Are there plans to expand and maybe have another unit? Or?
You know, it's been such a successful program. We haven't had that conversation yet. You know, we did on the mobile diabetes side. Probably worth having a conversation about it. Yeah, it's
Sounds like there's a need.
something that just increases engagement and increases connection with the community.
Certainly when people see the pink coach around, I think
It's
they know what's
recognizable,
going
isn't
on.
it?
Yeah.
Yeah, it really is.
Also, how often, that's really incredible that OB/GYN and cardiology are at that primary care site. How often are they there?
Oh, it's itinerant, you know, weekly, monthly, depending on the schedule and how they can make that happen. We have some great physicians that are committed to that. They really engage with the community. That's their focus now. They were very busy cardiologists for us for a long time, and as he sunsets his career, he found that as a passion, and we were absolutely willing to give him the stage for that.
Awesome. And Sorry, I had one other question. For the colorectal screening, what's the method that you guys are using? Is it Cologuards,
the
FIT
box, isn't it?
tests?
The box and the occult test.
Yeah, box and occult.
And what, like, how often are people returning those, and what's the process for that?
It is a community process where at the events they enroll and then they're able to distribute them after that. And I don't have the results for how frequently the results come back. Yeah. Yep.
Thank you for your presentation. I am a proud alumni of Methodist College. I was
Congrats, and thank you.
Thank you. I was there as a surgical technician for 12 years.
Mm-hmm.
But now I'm proud to be serving my community, and I also want to thank you for your partnership. I was able to create that partnership to bring the mammogram bus to the Latino Center of the Midlands.
Great.
You guys have been serving my community for over 4 years, serving over 400 women in those 4 years of partnership. So thank you for that. My question is in regards to your behavioral health services.
Mm-hmm.
I'm really grateful that you are in OPS and in Metro Community College. Could you tell us a little bit more about that process, being that these are minors?
Mm-hmm.
So is there a consent that needs to be signed, I'm assuming by parent, before a child can have those services provided?
Absolutely. I guess to begin with the identification of the need, it's either self-reported or parent-reported or through the school counselors or administration. That's the unique nature of it, is they are elbow to elbow with the school counselors who have areas of focus which are much more oriented on grades and on school and on vocation and future. Whereas these behavioral health issues stand as a barrier between all those areas of success. So these licensed mental health practitioners standing elbow to elbow with the school counselors are there as an asset to help them eliminate the barriers from a mental health perspective so they can really focus on those things that the schools are there for. Yes, the consents are there, and yes, that is a process that before any care is provided, the consent's performed.
And then a last question, do you know if those consents are provided in multiple languages?
Don't know the answer to that. I would suspect at areas where there's need of that's something they were looking for. If not, I'm going to follow up on that. That actually area is under my tutelage, so I'll follow up on that.
Thank you much.
Yeah, you're very welcome. Okay, great. Let's move on. So last time when I presented this, I informed the board of some efforts in the area of social determinants of health. It was a program at that time we were standing up. I think this year was a perfect opportunity to give some great highlights of the progress we've made and our efforts on addressing needs in our community for social determinants of health. With that, I think an expert is probably necessary to go into some of the details. She has about 8 minutes to give a discussion about our efforts at Methodist Hospital. With that, I'll introduce Becky Jizba. She's the service executive at Methodist.
Thank you, Jeff. Good morning, everyone. My
morning.
name is Becky Jizba, like Jeff said. I'm a nurse executive for Methodist and Women's Hospital. So this has definitely been a passion project for me, leading the social drivers of health for the health system. And I helped facilitate that work over the last 3 years. So first I'm going to take you, this has been a journey, right? This has not been something that can be accomplished in 6 months to a year. We've been working on this since 2023 formally, but of course, since day one we've opened, we've been taking care of our patients and putting them first and taking care of them holistically. And there had been screening happening in certain clinics, certain areas, but in 2023, we really started to formalize that, right? So we've been on this journey, and the first step was to screen all of our patients, right? And that is a pretty heavy lift when we're talking about thousands and thousands of patients and individuals that come through our doors every year. So we'll talk about how we accomplish that here in a minute. Trying to really not only screen and assess, but address, right? We have to, if they tell us something, we should probably take action. And so working with our community partners, because they truly are the experts in some of these social drivers of health. The hospital can't solve all those things, but we can definitely partner with our community to make sure we meet those needs. And so really right now we're kind of in those last two bubbles on that spectrum, and that really comes down to integration into our medical records, as well as really sharing data across our community partners so that we can all be talking the same language and taking care of the patient holistically or the client. So how do we screen our patients? That's always a big question that people ask me, because we screen 100% of the patients that walk through our doors in the hospitals. And how do you do that? Because that can take a lot of time. These are really sensitive questions that people might not want to answer. But what we do to begin with is we screen. And so we ask a question when they come in our doors, you know, have you had any trouble in the last year with obtaining or providing housing, food, utilities, transportation, medication access? We always have asked our safety questions, but this really helps us kind of then filter it to those who, one, want to tell us and maybe would like some help, and then we get into a more detailed tool to assess their needs. And we use the Prepare tool in most of our areas, as well as a tool called the WellRx, which is a Cerner product. But those are the tools we use to then get down to the nitty-gritty. And we do that with 100% of our patients that walk in the door. So of course, the big question then is, well, what have you found? Since we've been doing this since 2023, what is our population telling us are their challenges with social drivers of health? And one of the top ones is transportation. Those who screen positive for social drivers of health and tell us they're having challenges, 19% of those tell us transportation is a challenge. And I'm guessing that's not surprising to a lot of individuals in this room. Housing is the second one. Affordable housing, consistent housing, stable housing, that's around 18%. Access to medications is a challenge. A lot of that has to do with, like Jeff said, cost, but also access. And then food comes next, and then it just keeps going. So this has told us a lot about our patient population, because what we want to do is then take this information and partner with those in the community that are really good at transportation or housing or getting access to medications and food security. How can we partner as Methodists with those individuals to then help our patients the most? Okay, so how do we do that? We have partnered with our Nebraska Health Network, which is our accountable care organization, to launch Community Relay. Now today, you guys could Google Community Relay and it would pop up for you right now, and you could access it, which is the beautiful thing about it. There's no passwords or codes you have to put in. You put in your zip code and it will tell you what's around you, what are the resources, food, legal, childcare, access to medications. It will give you a plethora of community resources that are in and around your area. So we have partnered with Community Relay, which is powered by Find Help, which many of you have probably heard of, to give this resource to our patients. Those who don't want to share with us these sensitive things that they're having challenges with, because we know they might not want to tell us, we do have a QR code in all of our paperwork that we give patients that they can access this themselves if they'd like to. It also is translated in many, many languages. So that's another beautiful thing about it. This past year, we were able to integrate this into our electronic medical record. So what's beautiful is that then our community health workers, which I will talk about in a minute, they can help hold our patients' hands through this process. We don't just give them a link and say, good luck. We're able to send those referrals, talk to those community partners, and really connect them to those resources and hold their hands through it. So I'm going to just highlight a few of our partners we've worked with over the last couple years. There are so many, but this highlights maybe some of those areas for social drivers of health that we have connected with. So when we talk about supplies, diapers, of course, is a big one. We have a huge women's health population. We partner with Nebraska Diaper Bank in this past year, and we have served 228 families and given out over 18,000 diapers. So that's just one example. Housing, this has been a beautiful relationship in this past year. Vita Nova Housing Resource, this is in Papillion. Pregnant women can live on campus during pregnancy and up to 12 months. In the last 6 months, we've been able to house 5 moms. So that's huge, that's life altering. For food, we partner with a company called Mom's Meals, and we've really tried to hone in on the populations that this really truly impacts their health outcomes. So a good example of this is our congestive heart failure or cardiac population. How can we make sure that they're getting that medically tailored diet so that they don't just bounce right back to the hospital, right? And so we've been able to partner with that service line and work with this company so that when patients are discharged, we can actually give them 30 days of free meal, 2 meals a day that are free, that are delivered to them and tailored for that congestive heart failure diagnosis. So this has been a really beautiful partnership, and we're actually going to expand that this year to some of our high-risk moms. So transportation, of course, is also, like you saw, it's a big one. We've partnered with Lyft and the Methodist Hospital Foundation to help support our patients with that service and pay for it. Because we know that that follow-up appointment to get to your provider, to get to your home, if we can't do those things, then you're not going to be able to access care, right? So, and then I'm going to talk about our community health worker expansion. So we've been on this journey with community health workers for the last few years, and it has been just a beautiful, wonderful relationship. Community health workers are typically non-licensed individuals that look and talk and act with your community, the people you serve, so that they can be a trusted resource. They're not walking in the room with a white coat. They're walking in just as another person, right, as another peer. And so we actually have community health workers embedded in our hospital so that when a patient is there, we have them meet the community health worker. They can engage and build that trust and that relationship so that when there are needs, that individual can help connect them. And it's not just that initial connection, it's that follow-up too, right? So like Jeff said, we wanted to make sure we had a hub for people to meet that community health worker once they've been discharged, to make sure things have actually happened, right? So the Methodist Community Health Clinic on 26th and Douglas is a site that we can meet patients for that follow-up. We also know our emergency departments, that is a heavy utilized space for individuals that have social drivers of health. And so this year we're excited to really embed a community health worker. We've already started it, but to really embed someone in those emergency departments to care for those individuals so that we can help them with those things that are bringing them back to the ER over and over again. So this just continues to grow. We are so grateful for the community health worker program and those individuals that serve our community. So I just want to share one story to really bring this home. What's a community health worker and what can they do? So here's an example. We had a patient that was a pregnant mom. She already had 3 kids at home. She had recently lost her job. So she was in a tough spot. So her income was really not there. She was working with her landlord, who had shared with her that he felt that she did not pay her rent and that it was overdue. She was pretty sure that she had paid her rent and that she had done those things. So what the community health worker did was first make sure those kids have food. Let's make sure the family has food. Let's get them to the pantries, make sure they know where to access that. And then the community health worker actually sat next to that individual and called the landlord and got the paperwork and spoke with that individual and made sure that that was taken care of, that this person had a place to go back to go have a home with her children. And this patient could not have done that without a community health worker to really sit by them and advocate for them so that their housing could be secured. So that's just one of hundreds of examples of how community health workers can really help our patients and people in our community. So that's just a really high level, what we've been doing with social drivers of health. Anyone have any questions for me?
Becky,
Yes.
You said everybody that comes to the door fills out this form, right?
Yeah.
So what physically happens to that form? So they then hand it to
Great
somebody?
question. Great question. So, so the nurse that's admitting the patient, because everyone gets it when they're walking their doors, if they're getting admitted, there's a form that's electronically filled out, and that if there's any positives, like we click a button there, it will automatically send a referral to our social work and community health workers to then come see the patient. Okay. And so we've really built that in the background so that there's no one that we lose, right?
Okay.
Yeah, thanks.
Do they get both a social worker and a community health worker in those instances, or does it depend on what services they
Kind of
want?
depends on what the service is that they need. It's such a team effort. They're under the same umbrella, the social worker and the community health worker and our care coordinators, which is intentional because there's so many things that overlap. So at once we may think it's medication access because of financial constraints, but maybe we need to talk to the nurse or the social worker to get that med changed because it's too expensive, those sort of things. So they definitely work in tandem, and most of the times that patient will see all 3 disciplines.
Okay,
Yeah.
great. I have a few more questions for
Yeah.
you. How are the women connected to permanent housing in that housing program that you have, where they can pregnant mothers can be there while they're pregnant and
Yeah.
then up to 12 months,
Yeah,
right, after
yeah.
their pregnancy? So what's the plan, or how do you connect them to more permanent, sustainable housing?
Yeah, so that housing company is really the ones that will connect them with future housing since they're going to be there for so long. And we're just trying to really build that relationship. So we're kind of still in our infancy, but we know that there's an application process to get into those sort of housing situations, but then that company will then have those resources to then connect them to future housing. But of course, if they continue to be our patient or our, seek our services, we would follow them along in that journey.
Okay.
Yeah.
Is a community health worker at all linked to that process?
Yes, they have built that relationship with that
Okay.
company and then follows it along.
That's great.
Yeah.
And then for that meal program,
Mom's Meals.
Yeah. How long do the patients receive those meals?
30 days.
30
So,
days.
Yep, for a whole month. And now if the individual wants to continue that service, they could. It's just those 30 days we pay for it.
Yeah.
Yeah.
And then once they opt out, well, not really opt out,
Yeah.
but that they
Graduate. Or,
yes.
Yeah.
How are they linked to make sure that they continue to have sustainable meals post program?
Yeah, for sure. So when we are with that individual, we set up that service, but we also make sure they have other resources, right? So that community health worker can give them the resources for if they need food pantry, or if they need to know where the grocery stores are around them, or if transportation is really the issue to get to those grocery stores, right? And so we try to prep as much as we can, knowing that service is limited, right? It's only 30 days. So how can we continue that journey afterwards? So
That's
good question.
great. I mean, I love community health workers. You don't have
Yeah.
to sell me on it because
Yeah.
I'm already locked in.
Yeah.
I teach in the community health worker training program that we have at UNMC.
That's
so.
we put them through that program.
Yes,
So that's
I know.
part of our
Well,
obligation. Yeah.
Yeah, no, I appreciate it.
Yeah.
How many community health workers do you have working with you currently at the Methodist?
So in the health system, there's quite a few, but for Methodist and Women's Hospital, we have one right now. We're about to hire a second one, and then we're going to put a third one in our community health clinic, where that will actually serve the Coons Commons as a whole. So we'll have 3 total for our Methodist Women's hospital-based clinics, but in the health system as a whole, there's probably 10 to 12.
Okay,
Yeah.
that's nice to know. Do you feel like that number is sufficient for the programs you have and the demand or need that comes
I
in?
think as we continue to build the relationships with the community and able to destigmatize some of these things, I think it's going to grow, so patients can tell us their challenges. Also get into the clinics, because right in the hospital, it's really that blip of time, but at the clinics is really where you build those relationships with your primary care and things like that. So I have a vision that it will grow over time, just because they're such a valuable resource.
Absolutely. Have you had any challenges integrating them into the clinic and kind of the structure? I know in the past challenges have been around the budget and finance and
Sure.
structure for paying for community health workers to become permanent fixtures in the healthcare team. So have you had any of those types of challenges?
I think these past years when we've had it kind of be grant funded or
Right.
foundations have supported us, we've proven the concept. And so I'm excited for the next few years to watch that concept grow and to have that buy-in. I think anytime we put a community health worker in a site, everyone is so grateful and sees the benefit. We just have to get in there, right?
Absolutely.
So, and we're still on that journey, but it's continuing to grow. So.
Awesome.
Yeah.
I love that. And then last question, if you happen to know the answer to
Oh,
this,
gosh, yeah.
what are your plans for how you will want to increase the number beyond grants of community health workers? I'm sorry.
Oh, of community health workers.
Yeah.
I think that is like proving our story, right? To say that this is the cost savings that come with the community health worker and the budgetary constraint sort of thing. But working with our primary care providers, working with our physicians, so that we can also capture the patient population. That's such a big piece of it, right? We can tell the soft stories all day, but if we can't capture it to say, hey, no, 50% of my population has financial constraints, 50% have transportation. So really getting into the documentation of it as well, which we've done a ton of work in the last 2 years to make sure things are coded and flowing and all those sort of things. So part of our plan is to truly just capture that population as much as possible,
Yeah.
so that we can prove that concept to say, if 50% of your population is struggling with this, then let's take care of it. So then we can save those costs down the line, as well as help that individual,
Yeah.
of course. So it's a journey. We just continue on. So
Oh, good.
yeah.
Thank you for your presentation, and I appreciate the use of community health workers and how
Yeah.
it's starting to be integrated into the healthcare system
Yes.
here. I think it's been a long time coming,
Yeah.
and it's nice to actually see it in action, and then being able to see some positive health outcomes as a result. So thank you.
Yeah, you got it. Yes.
Yes, thank you. Just to piggyback on a couple of Dr. King's questions there. So this is all 100% inpatient that are screened, or are you talking inpatient and outpatient?
So if they walk through our front doors, whether it's inpatient, observation, outpatient, they're going to be screened. And then in the clinics, it kind of depends on the clinic, but most of our clinics are screening their patients as well. It's just maybe different in when that happens, right? So it may happen on that first visit, it may happen on that follow-up visit, but in a year, we want to make sure that everyone gets screened at least once in those clinics sort of scenarios when they have those frequent visits. But yes, so if you walk through our front door, you're going to get screened.
Okay, that's
Yeah.
awesome.
Yeah.
And then who's following up on those on the outpatient side? Do you have a community health worker that's also designated?
Yeah, so
there?
that's part of the design, is to have that community health worker then follow it through. Now, it's one individual, they can't do it all,
Right.
right? So what's beautiful about the documentation we do is it flows to that outpatient arena. And so let's say we screen them and we see all these things in the inpatient during their acute stay, it's gonna flow and you're gonna be able to see it if you're the primary care provider and they come to you as a follow-up, or if you're the cardiologist, or if you're whomever it is, they can see that documentation flow over for what those challenges were and what we've addressed. What's really wonderful too about that community relay database is that we can see if follow-up has happened as well. But it's in that database. Part of the journey is to get that into our electronic medical record to say, did that actually happen, that follow-up. But yeah, so they have visibility.
Okay.
Yeah.
And that was my next question was, where does it live within the EMR? Like as a primary care physician,
Yeah.
where would I see that?
Yeah, so for physicians, for providers, we have it flow into their progress notes. So anything that the community health worker or the social worker would document in those screening tools, it actually flows into their hospital progress note, and then it gets into their discharge note. So once it's in their discharge note and you see them on the outside, if you look at that discharge note from the hospital, it will all be there.
Okay.
Yeah.
And you find that most providers and physicians are seeing this? I mean, I know we get a lot of
Yeah.
note bloat.
Oh, I
and
know. Yes.
Things
I hear about it all the
automatically
time.
auto-populate. And so I'm just wondering, like, is that something that could live on the problem list if it's
Totally.
a food insecurity issue, or how is it made more aware and brought to the
Yeah.
attention?
Yeah, it's a journey, I would say, with each provider. Their flows are all a little bit different. But I would say we have a highly engaged medical team that want to know these things about their patients. We take those suggestions all the time. Could it live on the problem list? Could it live someplace else? And so we continue to morph and change when appropriate. Right now, we're at the journey where it's in their discharge note. That's where you can see it. But I do foresee in the future that it will morph over time into what's convenient or in the workflow of those providers, because that's so important. We don't want them to go 50 different places to look for things. But people are getting more engaged. They're seeing it. Of course, in our community, these constraints are getting harder on our patient population, so it's becoming more prevalent, right? So I think we have very engaged medical staff, and so I think it'll morph over time.
Awesome.
Yeah.
And then lastly, about the LIFT partnership.
Yeah.
So those are just for the hospital follow-up visits, I assume? And is that like set up at discharge automatically?
Currently, that is the
or-
process. Yeah, you got
Okay.
it. Yeah, some of our clinics, especially some of our specialty areas like our oncology service line, things like that, they have partnerships as well to take patients to follow-up visits, things like that. But for us, that partnership is in the hospital with LIFT to get them home and to get them to those follow-up appointments that are immediately after the hospital.
Awesome, thank you.
Yeah. Anything else?
Let me ask you, because this I'm figuring this might be. Let me ask you about somebody about the rural program. Explain to me. Give me your definition of rural, and explain to me how that works. The rural outreach program you mentioned earlier in the slide.
Rural outreach.
Yeah, no, I mean, I was trying to wait to the end for my question, but I mean, give me your definition of rural,
Jeff,
and
the
then
definition of
explain to
rural,
me
would
how
you?
it works.
Yeah.
Because I'm
Can
just
I
saying.
get to that?
Oh, okay, you got.
Just want to thank Becky for coming and did a great job and great questions too, and also see why I brought Becky, quarterback of the process. She's really been doing a good job leading that effort, so I'm proud of you. Okay, rural definitely depends upon which service line we're talking about. Our catchment area depends on the specialty. You might be tertiary care, quaternary care, where you have a very large multi-state region, where you might have a different specialty that you have all the patients you need within a 50-mile radius. So rural could be Saunders County, it could be Dodge County, could be in Iowa, could be Potawatomi, could be Mills. But we do have some that reach out across both states, Nebraska and Iowa, some up into South Dakota. So it is. Our efforts from a perinatology perspective, which is probably the one you were looking at when I mentioned the rural outreach. Yeah, that's mostly Nebraska.
No, I'm just curious because, like you said, you got the. This is your hub, but I'm trying to see if that's the metro statistical area that's rural because you got Saunders, but you got Cass. You got,
Yeah, within the MSA for sure.
Okay.
Yep.
All right. Is it outside the MSA?
Yeah, absolutely.
How far?
We'd go statewide for perinatology. We have relationships all the way out to the Colorado border, up into the Panhandle.
Oh, really?
Yeah, yeah. It's been something that as that service line has really established that regional leadership position, they're looking for more opportunities. It's a real crisis mode when you get outstate. Those birthing deserts are a big thing. You deliver 25 babies at a hospital a year, you don't have the competencies to continue to do that and build talent. And we serve a role in that. We are that hub.
I'm sure, what are you projecting with some of the changes that have happened over the last year? How do you expect that to
In terms of
rural service? What people are
yeah,
projecting?
absolutely. They're going to focus their investments on that, on what they see as priorities and health needs in their communities. We're just, that doesn't necessarily affect the birth rate. There's only so many babies being born in those communities. Funding or not, does it make sense if you have the funding to have a program that just doesn't have the volumes to keep competencies up? That's probably more the challenge than it is the funding. Now, other health services, different issue, but specific to the rural outreach for our mothers, women's, and babies, that's the area challenge.
No, I'm just curious. So the federal law starts going into effect, and you all are pretty strategic in how you look down the line. I'm just, they put money into some rural efforts, but now that you got this rural project, I'm just curious, what are you all thinking, or what's the discussion on what really is going to be the impact on rural services and how that might have to be picked up?
Well,
particularly with
I
hospitals
can tell
closing and
you
stuff like
that in specific, you want overall rural or
No,
just
I'm
our
just
impact?
curious because
Yeah.
on you all's, I'm sure you ought to be looking at that because some people say that this money's not going to be enough,
Yeah.
and that some closes are going to happen. I'm just curious what
They
you all
are.
thinking.
Yeah, I think what we're seeing, and we've been following the trends, and I'll just speak specifically to babies being born first because we have the statistics on it. The rate at which hospitals are stopping doing deliveries, where they do not even offer the ability to deliver a baby at their hospital, is staggering. Small hospitals just aren't doing it. And now moms, when they go into labor, are having to drive farther and farther to larger communities. And those larger communities are looking to us to help support them and build their programs up from an education perspective and taking services there. Overall, yeah, the rural health critical access has been a program in place for quite some time that's really boosted them up. With that, challenges in population, the brain drain's not stopping. People are moving out of those rural communities, and services are going to follow it. Is it a more efficient use to have them come to the metropolitan areas?
No, you just happen to be the first, but that's a question I'm just curious to
Yeah,
ask everybody
interesting.
what the real world implication of
Yeah,
that is going to be.
and let me get to the next federal program on this one, because this is usually what I hit on from a federal perspective. To help you out with purview into how we quantify our community benefits, the IRS Code 501R requires us to capture these dollars. So this is the investments that we make into the community. It's done into three major buckets. The first one is financial assistance. It's at $22.7 million. The next one is the losses that we take from governmental programs at $56.8 million. The fact is that reimbursement from Medicare, Medicaid only cover about 80 to 85% of costs of those patients. That loss, that 15 to 20% is what constitutes to this dollar amount. Now, here's where the federal programs, Commissioner Rogers, you're speaking of, impact. As programs like Medicaid-directed payments come in, they look to make hospitals more whole, reduce the loss, so essentially reducing the size of that particular light blue slice of the pie. So what happens with those dollars, and this is the question that we're often asked by this board and by others, is those dollars then funnel directly into the teal wedge, which is our community health improvements. So we expect the light blue, as programs are implemented there, to go down, the teal to increase, and what do we do with those increases? We call it reinvest. That reinvestment is going to be in early identification, behavioral risk education, health equity, and social determinants of health. So it's a shuffle of dollars, but those are dollars that are coming in from a subsidy perspective and then funneled into programs that directly impact the community.
So this is going to be my ask for everybody.
Yeah.
Can you make note of where you are now? And then when you come back next year, I would like to see where you all were in that investment in 2018.
Yeah.
Because I'm particularly trying to see what's going to be the loss when Medicaid expansion came into effect here.
Yep.
and then now what's gonna be the loss based on the federal?
Yeah, we'll
pay.
trend
So,
it out for you.
Yeah. so
Absolutely.
it's gonna be my ask to everybody. Like I said, you happen to be the first, but I'm
We'll be
curious
there.
to see what the loss is, what we gain in the state with Medicaid expansion,
Okay.
and then what we're gonna lose with the federal piece. Nah, I mean, it's like, I know what the Fed says, there's the reality, and that pot's gonna be lost. We gained in 2018.
Uh-huh.
There was a setback in 20 with COVID because of realisticness. Now, I'm feeling like there's going to be loss, and I just want to see what everybody's loss track is. And
Yeah, we'll trend that out. We can go
Okay.
back a couple of years for you too.
Appreciate it.
Okay? Ultimately, the goal of all that and that reinvestment is being the best partner for residents in Douglas County. I introduced you to my team, and when they came on board, there was 3 things I asked them to do. One was to promote involvement of Methodist Health System in the community, to get out there and really cheerlead for our folks and get them involved. I think you can see our results are speaking for that. The next one was to quantify. We needed to be able to identify and quantify all the community benefit investments that we were making in the community. Our pie chart is evidence of that, and we want to make sure, and Commissioner Rogers' great point about trending that out, you can't improve what you can't measure, so we want to make sure that we take those dollars and use them, and we want to analyze them and use them correctly. And the last ask of them was to increase the number of partners that we have in our community. All the work in the social determinant space that Becky referenced, all the programs that I brought up, most of them had in partnership with or in collaboration with. And I think that's really what this is all about, is us as a health system connecting with those in the community that are really there, also making the impact, some of them with more competencies in that space than we do. We need to find them and we need to engage them better. So ultimately, with the goal of improving the health of our communities, that's why we present this list of you. It's well over 200 partners in our community, and that list is growing.
Okay.
Be happy to answer any questions. You guys asked great questions through the course of it, so if you have any left, I'm here, or my team can answer some questions as well.
No, appreciate it.
Right.
Well, let me say, just personally, since we started doing this, I have appreciated how you all have continued to evolve your report. It's definitely reflective of the seriousness of it, and just seeing how the staff has reflected through the years. I've grown to appreciate you all's report, definitely over the years, so I appreciate your effort.
All right. Thank you for the compliment, and we appreciate the time.
Alrighty.
Right.
So, just for the record, we were supposed to, John and I were going to transition today, but he had an emergency at a restaurant. And so I'm going to there's going to be a little bit of a tweak here where we're going to hold off the item C presentation. So Dr. Hughes, I'm going to ask you to get ready because I might have to leave at 9:50 at a hard piece. But we're going to go back, approve the minutes, approve the agenda items, and then I'm going to ask Dr. Hughes to come. And because that student presentation is there, if I walk out and there's not quorum, that could still happen without me there. So I want to make sure that happens. So let's go back to the agenda, to the minutes, and I would ask for a motion to approve item 2 for the minutes for December. Is there a motion? Okay. Motion, Dr. King, second, Dr. Jones, roll call. Yes.
Wilkin,
Yes.
Rogers,
Yes.
King, Jones, Espinoza. Okay.
Okay. We'll go to item 3. I'd ask for approval of items C through
L.
L. Is there a motion to approve items C through L? There's a motion by Wilkins. Is there a second? Second by King. Any questions? Roll call.
Rogers,
Yes.
Oh. Wilkin, King, Jones, Espinoza.
I'm going to take A and B separately because I'll need to abstain. Is there a motion to approve items A and B? No, as long as we got quorum, we good. There's motion, Dr. King. Is there a second? Second, Espinoza. Roll call.
Espinoza.
Yes.
Jones, King. Rogers, you abstained.
Yep.
Okay. And Wilkin. Okay.
All righty, now we're gonna move to Dr. Hughes' report. Yeah, we're gonna come back, yeah.
I promise to be quick. Welcome to 2026. Some updates for you. First, I thought I'd start out with a foundation update, let you know some additional paperwork was requested by our attorneys, so I got that signed and back to them. I have some invitations out to potential additional board members, and our attorneys have drafted the bylaws, so very happy I didn't have to draft those. And the hope is, the goal is for our first meeting in the next month. So I am hoping that by the time we have this meeting next month, I can report on our first meeting to you. I wanted to also let you know, we've talked about, I think over the past year, maybe two, that the Regional Health Council has expanded. That's the group that comes together to really carry out the community health assessment and the community health improvement plan. Given how large it has grown, we identified the need for a governance structure within that council, and I'm very honored to report that they have elected me as their inaugural chair. So I will be chairing the Regional Health Council and will be working very closely, obviously, with the Wellbeing Partners. The CHIP will be, the final is coming out for approval here, I think, in the next couple of weeks. And then we will really be jumping right into planning for the next iteration of the community health assessment. I've also been honored to be serving on the Mayor's Homelessness Task Force. Right now, that group is composed of some leaders around the community, and right now the focus is really on standing up a framework by which we can recommend essentially actions, evidence-based strategies for addressing our homelessness issue here in Omaha. I also was able to attend the homelessness memorial that occurred on December 21st, which was essentially a memorial service for all of the homeless who have lost their lives in the past year. That was a beautiful service that was held outside at Jean Leahy Mall and held by the city and also some of our shelters here in town. And it was, I think, a really lovely way to not just remember those who have passed, but to also continue to bring awareness to the need for, to address the issue at large. I'm sure all of you remember the email I sent you about addressing the coal burning vote that occurred at OPPD in December. I wanted to follow up and let you know that I have been able to sit down and meet with Craig Moody, who is one of the executive director or board of director members for OPPD, and I'm very hopeful for a great partnership there. I also have been having conversations with Creighton, UNMC, and other partners in the community about what it might look like going forward to really do increased surveillance, monitoring, and reporting for that part of our community. And I'm really looking forward to more work on that end. If you follow us on your socials, you may have noticed that we have been putting out more videos. One of the things that we've started doing is a weekly respiratory forecast since it's respiratory season. And so this is basically like a weather forecast, but for the flu, COVID, and RSV. So you can look for those on Fridays is when we're taping those and putting those up. We've also started to include some of our other programs and doing videos. For instance, yesterday was the launch, the actual go live date for our food handlers training, and we had a couple of our food safety individuals who recorded videos, and we put those up just to help inform the community of what's going on there. On that note, I also wanted to just let you know, we did a soft launch for the food handlers modules training system about a week ago. We got 40 people who signed up right away, and then yesterday was our go live date. I think it was yesterday, right? Yes. Time's moving really fast right now, and we've already had 50 people or 40 40 plus, over 50 with the soft launch, 40 that signed up just yesterday with that being our go live date. So that is going really, really well. This week, I had the honor of attending the city's 8th MLK Junior Living the Dream competition for 7th through 12th graders. This was a fantastic opportunity to see our young people in the community come together, creating all sorts of artistic and creative pieces to bring really attention to, first of all, MLK Junior's dream, the work that he did, and also the work that we still have to do in terms of equity in our world, really, but especially here in our community. And I just want to put a plug in. You should go next year. It is absolutely phenomenal. I walked out of there inspired and really feeling a lot of hope, given the amazing young people that are coming up and probably going to be really strong leaders in our communities. I also wanted to give a very quick update regarding our building and just let you know that my deputy director and I have been able to have some really fantastic, productive conversations with several of our county commissioners regarding how we can do a better job of making our building livable. And those conversations are going very well. I can't say a whole lot more than that right now, but I'm hoping when I come back next month, I can give you some really great news on that. Also, legislative session is well underway. Today is day 10 of that session. It's a short session. The last bills are slated to drop today. Of interest, this afternoon, LB 760 is being heard in committee. This would move more environmental health responsibilities out of Nebraska Department of Water, Energy, and Environment and actually put these services on the cities and counties, which essentially means that the health department would have to pick up some work there. We are planning to come in neutral on that. We have a lot of questions and are very hopeful that we will be able to get those questions answered and addressed and hopefully have something good going forward that we can support. I was also able to attend a press conference on the 9th for the 25th anniversary of the Healthcare Cash Fund. This was Speaker Arch and Senator Von Gillern who spoke at that. It was spearheaded by Amanda McGill, and several local health directors did attend to basically stand behind the senators and show our support for continuing the Healthcare Cash Fund and protecting that money for what it's meant for. LB 912 is the Community Health Worker Bill, which I think, based on the questions we heard today, some of you will be really interested to hear about. This was the bill to certify programs that train community health workers. This is the first step in setting up everything that needs to happen in order for entities who utilize community health workers in clinical settings to be able to bill for that community health worker time. So this is very important in terms of speaking to sustainability of those community health worker positions and hopefully being able to expand them in the future. Very happy, Brian Harden, who is the chair of the HHS committee, introduced that bill for us, which is a very, very good sign, and the hearing for that will be at the end of the month, and I will absolutely be in that room. Tomorrow is bill review day for NALED, and so I will be in Lincoln, and we will be going through all of the bills to decide what items we want to prioritize keeping our eye on. There are well over 1,000 bills, so certainly we can't track all of those. And so I just wanted to let you know, last year I had that legislative tracker that was set up on your intranet site, and that will be populated again. I actually take my laptop and kind of work on that as we're going through the bills. So hopefully by the end of Friday, you will be able to kind of see what's prioritized and what's happening with certain bills. And that is all I have for your updates. Any questions?
And because the speaker's usually on back there, what's that bill number again?
912 is the community health worker bill.
Okay. You mentioned the cash fund. I'm assuming we got off the hook last year with his mistake what are you all planning for Friends of Public Health wise in regards to what may be what in the bigger picture of funding?
Great question. So in the bill that, and I believe it's still 261, LB 261, 260, which would be the governor's amendments to the biennium budget, public health was not specifically named, so that's great. However, we do know that there could be efforts to kind of sneak cuts into other legislations that would impact us, so we're keeping a really close eye on that. NALAD's priorities are the same as they were last year, which essentially is to protect funding and to protect authority. So there are, you know, we might have not been named specifically as a line item in his amendment, but that doesn't mean that there won't be potentially other cuts in other places. So we'll keep our eyes on that.
What a positive report today. I love this for you. For the governance for the regional health council, can you just chat a little bit more about the governance and like how your role as the chair is going to help to regulate what happens with the health council?
Sure. So it used to be just 3 people, essentially. It was just the health directors for Douglas County, Sarpy, Cass, and Potawatomi. We expanded that group to include representation from all of our health systems who wanted to participate. I think Boys Town might be the only one that opted out during this iteration, but they may, of course, choose to join in the future, and also our federally qualified health centers. And so, you know, when we had 10 plus people in the room, decision making and making sure when we needed to have conversations about things like the contract for the Wellbeing Partners, where we needed to maybe have conversations outside of their facilitation, it was very messy. We just really needed some kind of a governance structure. And actually Steve Johnson, Jackson, who was here with Methodist before, was a great advocate for that, and I'm very grateful for that. So this was essentially what was decided on by that entire group, that we would have a governance structure that is comprised of the chair, a vice chair, and a secretary or treasurer. I'm thinking it might be secretary. And so the hope is to have those positions filled by different system components. So we are the chair this year. We have Andrea Skolkin, who is federally qualified health center, and then I'm so sorry, I'm blanking on a name right now for our third from Children's. So we have, basically the plan is that, you know, it's not going to be all public health that is, you know, that governance structure. It's not going to be all the health systems that are only in that structure. So hopefully having a good spread and a good mix so that all of our interests are well represented in that, and we have a good voice for all of us.
Okay, cool.
Yeah.
I'm just curious, how long is your term as chair?
I think it's a year.
A year?
It might be 2.
You never know. It could be a lot of work.
This just happened, so I'm still, yeah, it could be. It could be.
Yeah. Okay. Thank you for that. That's the only a question I have.
Sure.
Thank you.
Thanks. Oh, evidently we have a comment here. I'm guessing it's probably the number of people who've signed up as of today. We are up to 211 users that have signed up for the training. So that would be between the soft launch and then yesterday's full launch. So that's very exciting. And I'm very proud of our food safety team for all of the work they've done to collaborate on this and also to get the word out into the community. So strong work, guys.
Yeah, I just want to know how big that is, because particularly the versatility you all showed at the city council meeting to make that work, it's a big deal.
Yep.
I'm gonna slip out and turn it over to Marty.
Sounds good. Thank you so much.
See.
Great. Thank you, Dr. Hughes. I believe we now need to move to presentations. Is the next one early findings from the 2025 nutritional environmental?
Yes. So
Okay.
I'm going to make sure we can get it set up here. Do I just, yeah, just click on her. Oh, that's not what I want. There. Okay. So we have a UNMC MPH Apex student that is going to give a presentation on our Nutrition Environment Measure Survey. So Alexis, I believe you should be able to share your screen and go ahead and start with your presentation.
Okie dokie, thank you. Right, let me know, can you guys see that okay?
Yes.
Okay, perfect. So like Leah said, my name's Alexis. Thank you so much for letting me present today. I really appreciate it. I am a DO MPH candidate. I go to medical school at Kansas City University, but I'm getting my MPH from UNMC. And I was introduced to the Douglas County Health Department for my applied practice experience project and my capstone project. So I will be graduating in May, which is exciting. Today I'm here to share early findings from the 2025 Nutrition Environment Measures Survey, which I will in the future refer to as NEMS, so I don't have to say those words so many times. And then I'll also include new perception data, and then I'll briefly discuss how these findings may inform future program directions. This is really high-level overview. This will be less than 10 minutes, but I'm looking forward to your feedback and any questions that you may have. Okay, so the NEMS is a standardized tool used to assess food environments. Traditionally, it focuses on the availability, quality, and price of foods. However, in 2025, DCHD introduced a new component, which is perceptions. This allows us to better understand how residents experience their food environments and not just what technically is available. So that tells us a little bit more. This survey was commissioned by the Omaha Metro Health Departments and collected between March and July of 2025 using multiple different recruitment methods. So starting off with the home food environment, many households actually report having the basic infrastructure needed to prepare food, like refrigerators, stoves, and microwaves, which is really reassuring. About 62% of respondents reported that they almost always have fruits and vegetables available in the refrigerator. At the same time, however, 24% reported that they almost always have candy and chips readily available at home. So this kind of suggests to us that while access exists for many households, people have the ability to cook different foods. Dietary patterns and convenience foods still play a significant role in everyday diets. Okay, so talking about neighborhood perceptions of healthy food access, when we look at this, about 68% of respondents strongly agreed that it is easy to buy fresh fruits and vegetables in their neighborhood. However, fewer respondents, around 41%, strongly agreed that the quality of produce in their neighborhood is high. Additionally, about 60% described fresh fruits and vegetables as somewhat expensive. So to me, this highlights an important gap to us. Availability does not always translate to affordability or perceived quality, which can influence purchasing decisions. So if someone is walking into the grocery store and they notice that the fresh foods are more expensive than the chips, I would say a lot of people are going to go towards the chips if they are working with a tight budget. So let's talk about that new perception data that I mentioned in the beginning of the presentation. So this gives us insight to what people experience once they're inside of the store. About 43% of respondents strongly agreed that foods near the checkouts are mostly unhealthy choices. In contrast, fewer respondents, around 1 in 3, strongly agreed that they noticed signs encouraging healthy food choices. So I think we can do better there. Lean meats and low-fat products were also less frequently described as very easy to find compared to less healthy options. So this may suggest to us that store layout, signage, and product placement may influence choices at the point of purchase. And I think just from an individual perspective, we can probably all agree with that, just based on our own experiences. So what can this tell us? Based on these early findings, there are several potential directions for future programming. One area we can pay attention to is healthy retail strategies, such as improving visibility and placement of healthier options, maybe making sure they're closer to the front of the store, the checkout, and places that people are going to be visiting more often. Another way we can address this is addressing the affordability and usability, particularly where cost or quality is perceived as a barrier. A third area is hands-on nutrition education, which is really exciting. For example, the health department has already done this program and it's proved to be pretty successful. They've offered cooking classes in the past that have allowed participants to leave with the ingredients to prepare meals at home. And so given what we've seen around perception, cost, and confidence using foods, this may be a strategy worth revisiting, just because, you know, if people are able to learn how to cook with these foods, the fresh foods, the healthy foods, they may not be as scared or as, it may not seem as daunting to them to choose something healthy rather than a cheaper, more unhealthy option. So that was a really quick rundown of what the NEMS is and what my project is encompassing. But let me talk about the next steps. So the next steps include completing the full 2025 analysis, comparing findings with prior NEMS cycles where possible, and developing actionable recommendations in collaboration with DCHD leadership and their partners. I welcome any feedback from the board, particularly around priority populations, program feasibility, areas of interest. And if I can't answer any questions, Leah is there and she may help me field them. Thank you very much.
Thank you. I appreciate your presentation. Just for context of the data, you may have already said this and I missed it. Was this administered in Douglas County only, or?
Douglas, Cass, Sarpy, and then I may be missing one more. Is there one more, Leah?
Potawatomi.
Okay.
Okay, yes, I always forget that one.
And then what was your sample size for this preliminary analysis?
Let me see here.
So I'll start, Alexis, and you can keep looking to make sure. So with I call it the OG NEMS, that one we actually did all convenience and grocery stores. So within Douglas County, it's like 500 and some stores. So it's every store for just looking at pricing, affordability, like that piece with accessibility. But the perception side of it, that one I don't have off the top of my head. I'm hoping Alexis can find it.
Okay. That's the one I was interested in too.
Yeah, they had, I know that, so UNO, Bureau of Sociological Research conducted the survey for us, and I know they had trouble in the beginning trying to get enough participants in it. So I'm not quite sure how many did we end up with, Alexis?
It looks like a total of 283 responses were collected.
Yeah.
Not bad for having some trouble in the beginning.
They had, so I think they were going to locations first and collecting the surveys, and then towards the end, they actually shifted and mailed it out to several different avenues. So,
okay.
Yeah, it was
Shocking
definitely a
that was-
shift towards halfway, but they're good at pivoting and figuring out how to collect the sample size that we need.
Okay, great. And then Alexis, do you have any plans in your full data analysis to stratify your findings by zip code?
I mean, that sounds like a good idea to me. I think that when I looked at the different heat maps from the previous years that Leah has sent me, I think there definitely are trends there. So I think that that's something worth doing.
Yeah, I would encourage it, particularly because there are food deserts in certain parts of each of those counties. I'm obviously most familiar with Douglas County. And so I'd be interested to see like that 40% who felt like they had access to quality fruit, I think it was fruits and vegetables, and then the 60% who said it was somewhat expensive. I'd be interested to see what part of the county those numbers are really coming from, and if it's higher in some parts of all the counties really. But I think that would be really useful information to have.
Agreed. Thank you.
And then my last is, sorry, y'all. Last is a comment, not a question. For the cooking classes, so excited about those as well. I appreciate your energy for that. I think just as you think ahead, and you haven't finished the analyses yet, so maybe you don't go in this direction, but I think there's great partnerships with community organizations that do this work already, and that could be an opportunity to partner with like No More Empty Pots, which I know Leah's already familiar with. And then I know several churches also do cooking classes that have access to kitchens, like Claire Memorial, who has its own kitchen. And then in my building, in the Village Empowerment Center, there's a whole kitchen on the second floor that could be used if you wanted to do more of like a collaborative space to have it, and it's in the community, so more easily accessible to members of the community that reside in maybe even North Omaha or South Omaha for that matter. It's not that far to get to, but just throwing those ideas out there for you as you start to finish the full analysis and see what you find.
That's great. Thank you so much.
You're welcome.
And just to add on to that, so we have already started redoing some nutrition classes, and we're still in the very early stages of it, but we've been partnering with Whispering Roots. Extension office is coming, which is nice. They can set it up anywhere, so we haven't necessarily needed a kitchen right away. But I will take all of these and take them back to the person coordinating kind of our new cooking classes for us. But the great thing, Whispering Roots, is actually anyone that comes to a cooking class will be getting a CSA box with those fruits and vegetables that they learn to cook with. So
Nice.
there's a nice kind of output with it, if you will.
Yeah, no, that's great. I know the challenge with the cooking classes is finding the space.
Yep.
To have all the folks in the class together.
Yep.
But I think it sounds like you kind of got that figured out.
We're
which is
starting, like
good.
it's still, we haven't had a ton of classes yet, so I will definitely take these back to our team and add that to our list of places that we can work with, so.
Okay. Have you partnered or talked with, was it Gretchen?
It used to be the Gretchen Swanson
Yes,
Center.
Gretchen Swanson Center. Yeah.
Yes, and now they are the,
Yeah, they changed their name.
I should know this and I don't.
I don't know it, so.
Yeah.
So have you partnered with them or have you talked with them
We
about-
haven't talked with them currently.
Yeah.
But not saying that
it couldn't
totally have. Yeah. We just started working with Extension first because they already had some of those curriculum set up. So they have
Mhm.
like a 4-week class. There's a 6-week class that is all. And then Anna with Whispering Roots is also doing some like single one-time classes for nutrition as well.
Oh, nice.
But
Okay.
yeah, we'll definitely look into that and start talking with folks.
Yeah, awesome.
Yeah.
Thank you.
Yeah, thank
you, Alexis.
Thank you, everybody.
I think you have one more question, Alexis.
One more for you,
Or maybe
student
more.
Dr. Alexis. Great presentation. Thanks for the findings and sharing those out. I would definitely also second the stratifying by zip code and then also tailoring your recommendations for actionable items based on those results, I think would be extremely helpful in looking at what lives in those as far as grocery stores to try to partner with. And then just a suggestion to also consider streaming or recording those cooking classes too for folks maybe with mobility issues or unable to attend.
Yes, that's an awesome idea. I appreciate that.
When Dr. King mentioned something, I flashed on Metro Community College in terms of the culinary school. Not only might there be space, but also a really good opportunity for the students at Metro to interact with people from the community and kind of bridge that somewhat, gap in terms of healthy eating overall.
Mm-hmm. Yeah. Great idea.
Thank you very much for the presentation. Appreciate it.
Thanks,
Thank
Alexis.
you, everyone, for your recommendations. I appreciate it very much.
All right, so now we move on to Environmental Health Division report. No? Oh, we're skipping that. Sorry, I missed that. I must have tuned out. Okay, so we're down to department reports and updates. Oh, keep just once. No wonder. All right. So since there are no questions about division reports, are there any comments from the board regarding committee reports or any updates that we need to discuss? Hearing none, the next board meeting will be February 18th here in the Legislative Chamber. The committee meetings are scheduled on the fourth Monday of the month, and I don't believe there's a need for executive session. So having completed our agenda, may I have a motion for, to complete the meeting?
Motion to adjourn.
Thank you. Second? Oh, okay. Roll call, please.
Wade, McNally, King, Festerson, Jones, Rogers, Espinoza, Wilkin, Weiss.
Recording stopped.